for taking the time to participate in this important conversation about vaccine equity. The Black Planning Group put this event on because we thought it was important that concerns that are specific to the Black community be addressed. There are historical reasons for distrust, and there are many challenges in terms of equity in public health. So my name is Meredith Radlin. I'm chair of the Planning Committee and a member of the region's Anti-Racism Advisory Working Group. Before starting the session, I'd like to acknowledge those who made it possible. So thanks to the Region of Waterloo, which supported us with staff and with resources. And a special thanks to the planning team, a group of dedicated community activists whose commitment to equity is unequaled. They helped to plan this event, but this group is also the group that produced the vaccine fact sheet for Black communities, which is now available in English and the main 6 African languages. It's been distributed to various community leaders, but it's also available on the region's website. So we hope that you find this Q&A session informative and helpful as you make decisions about the vaccine for yourselves and for your family. We're going to recognize the planning team, and then we will hand over to the panelists.
So it's my pleasure to recognize the members of the Black Town Hall Planning Committee. This includes Fawzia Baig, who's the Equity and Anti-Racism Advisor for the region and the lead for the Community Engagement Committee. Nev Zachariah, who's an analyst in the Communications and Strategy Division at the CAO's office in the Region of Waterloo. Meredith Radlin, who's a retired school administrator who's representing the Anti-Racism Advisory Working Group. Marcia Smelly, a retired secondary school educator and a community advocate. She's currently the president of the Waterloo Region chapter of the Congress of Black Women. We also have Priscilla Muzira, who's the African and Caribbean Community Development Coordinator at ACCKWA. She's also a board member for the African Canadian Association and Bring on the Sunshine. Alice Penny, who's the chair of the African Canadian Association of Waterloo Region, who's the director of Bring on the Sunshine. Ismail Mohammed, who's a facilitator at Chandler Moab Community Center in the city of Kitchener. He's also actively engaged in equity advocacy. Lang Nkube, who's a community development coordinator for the ACB network. She works on developing and implementing equity-based strategies. Mikhail Belachu, who's an active member of the Ethiopian community and is also an immigration consultant, and myself, Effie Berrigan, a health program project coordinator currently working at Horizon Family and Community Services. So I'm going to now invite our panelists to introduce themselves as we begin the Q&A session. Thank you so much, everyone.
So my name is Akwatu Khenti. I'm a special advisor to the City of Toronto's Equity Initiative, addressing COVID inequities, and the chair of the Black Scientist Task Force on Vaccine Equity. Isaac?
Hi, my name is Isaac Odame. I'm a pediatric hematologist based at the Hospital for Sick Children. Thank you.
Trevor? You're mute.
Okay, my name is Trevor Aldridge. I'm a consultant with Brevitas Consulting, and we provide consulting services to drugs and medical devices and vaccine manufacturers. Formerly, I was the director at Sanofi Pasteur, which is one of the largest vaccine companies. And before that, I worked for Health Canada as a specialist. So that gives you a very, very brief bio.
Continuing in alphabetical order, Upton.
Thank you, Akwadu. So Upton Allen, I'm Chief of Infectious Diseases at SickKids at the University of Toronto. and a professor of pediatrics at the University of Toronto. And I'm a good friend of Isaac's.
I'm Zainab Abdurrahman. I'm an allergist and clinical immunologist. I'm affiliated with the McMaster Children's Hospital, and I work there in the capacity of a Special Immunization Clinic, so looking at aspects of vaccine allergy. And I'm also a member of the Black Scientist Task Force. Thank you.
Thank you all. And before turning it back to the moderator, I just have to acknowledge that we are on the traditional territories of the Mississaugas, the Iroquois, the Anishinaabe, the Chippewa. Treaty 13 governs it. And, you know, this is a baby step towards the creation of a new culture of full respect for the role, the continuing role that Indigenous people have played in our country and need to continue to play, and the collaboration that's needed to create a new culture. So thank you for that. I want to thank everybody for taking their Sunday afternoon to be with us this afternoon. Know that you're going to be an ambassador to your community. So you'll be here asking your own questions, but we expect that when you go back to your particular community, whatever it is, that you'll share that information as widely as possible so that we can really create a ring of protection as wide as possible around Black communities of Waterloo. Finally, libations is in order. You know, it's important to know that we wouldn't be here if it wasn't for the sacrifices of many ancestors whose names remain unknown. And one of them, 300 years ago, brought to Boston, probably from Ghana. They said West Africa, probably an Akan speaker. His name might have been Kwame, for all you know. But he was brought here in 1716, and in 1721, when Boston was facing its own pandemic, smallpox at the time, he told a priest, a guy named Cotton Mather, whose name would enter the historical annals of vaccinology. He told him that he wasn't worried about smallpox, and Cotton asked him, why? Why are you not worried? He said, because back in the village, they had a practice where they would stick the pustule of someone who had smallpox and then go around the village sticking people with, you know, I guess what would be a sample from the pus of the person who was ill. And in that way, actually, as the first record of inoculation. People in Boston at the time, the vaccine hesitancy back then was vaccine hesitancy towards an import from Africa. The Bostonians initially rejected the practice because they thought it was heathen and paganistic practice from Africa, and that Cotton Mather was mad. But time and science proved him to be correct. And it's very important for everybody to know that that tradition continued across the past 300 years. He wasn't the only one, but he was the first, this African man who actually didn't get any money, no copyright protections from what he contributed to North America. And so Onesimus, you know, we pour libations to Onesimus, this enslaved African whose ideas would serve as a foundation for this discussion that we are having today. So with that, allow me to turn it over to Neb, and you could take it from here. Thank you so much.
Thank you so much, Dr. Khenti, and thank you for that libation, that reminder of the importance of the conversations that we're having here today. Again, just want to thank our panelists for joining us today. We're so excited, so fortunate to be able to have such a knowledgeable group of professionals here to answer some of the questions that we have from our community. And thank you to the attendees for taking time out of your afternoon, as Dr. Khenti mentioned, to join us. And it's quite heartening to see how many people have joined because, as was mentioned, you will be the ambassadors for this information, sharing the information that you hear today, combating some of the misinformation that we hear. So very excited to hear what our panelists have to share with us. So I will be your moderator for the next little while. What we will do for the next 2 hours or so, we'll go through some of the questions that you have submitted at registration. And then Aika has just popped into the chat there and is welcoming any additional questions. So as we answer questions, or if there are other questions that you've thought of since registration, please feel free to put those into the chat, and we will be able to go through those after a bit of a break at 3 o'clock. So we'll just jump right into it. I will start with some questions around the safety of the vaccine. I'll pose the question to our panel, and I will let you all battle it out to see who gets the honor of answering the question. So we'll start with the first question. It's a big one, it's a broad one. Are the vaccines safe?
I can start the discussion on that topic. Okay, so in a word, you could say it's safe, but what do we mean by that? So just to clarify what this looks like, the whole process for developing a vaccine to the point where you have a product you can actually distribute is a very rigorous process. And a huge part of that process is to make sure that you have assurances of safety all along the way. So without going into very, very fine details, you have some critical stages of development, and a lot of that work gets done up front because you have to get to a point where you can actually progress from the lab bench to the point where you have something that you can actually inject into a human. So typically, I'll just simplify this as much as I can, because it starts way back in the process from the point where you start looking at the materials you want to have included in the formulation. You have to look at obviously for vaccines, we're talking about sterile injectables. So that by itself confers some huge requirements around that confer safety on the vaccine. If you're saying that your product is sterile, that's a huge impact on safety of the product. Then you have to go through clinical stages of study. And the first clinical stage, stage 1, there is a lot of work done to start demonstrating safety. And for one thing, not very many participants are involved at that stage, but some of the objectives there is to look at the dose tolerance, for example, to see how much dose a person can tolerate. Then as you progress through to phase 2 and phase 3, you're looking at more evidence for safety. In the case of the two first vaccines that we have approved on the emergency use, the Pfizer vaccine was the safety and efficacy was studied on the phase 2-3 clinical study, and the Moderna was studied on the phase 3 study. So in the case of the Pfizer study, there were about 43,000 participants in that phase 2-3 clinical study, where they looked at both safety and efficacy. And looking at the safety aspects of the study, this was a placebo-controlled study where you had half of the participants getting the vaccine component and the other half getting the placebo. So the objective is to look at the different, what was the results of the study in terms of any type of adverse events that showed up either through the vaccine part of the study or the placebo start. And in general, what we can say for Pfizer was that there were not very many serious adverse events. Most of the adverse reporting was, and by the way, let me just go back and highlight a couple of things, because this is primarily a Black audience concern. There were Black participants in this study. In the case of Pfizer, I think it was about 10%. It's either 10 or 9%, but one of the groups was 10 and the other one was 9. So in any case, there was Black representation in terms of assessing safety. So primarily, the adverse events were minor events such as fatigue, that sort of thing, and maybe some more systemic ones such as temperature, fevers, and so on. There were a few serious adverse events, but those were associated with allergenic responses, and I think there were a couple of anaphylactic ones. But it's also important to note that in this Pfizer study, there were a couple of I think 2 or 3 deaths, but none of them were actually vaccine related. There was no evidence that there was any reactogenicity. I think one was a cardiac arrest, and the other one one of them was, I think, there was nothing that was related to the vaccine. And in the placebo part of the study, there were, I think, 4 deaths, and again, none of these were vaccine related. So the evidence from the Pfizer study was pretty clear that based on this particular study, the phase 2-3 study, which we're using as our index study, the vaccines were safe. And in the case of Moderna, they had a slightly smaller study. I think it was around 30,000 participants, again, placebo-controlled, and similar results where you had no indication of safety issues either in the vaccine group or in the placebo group. So that's a very, very compressed explanation of the safety aspects of the vaccine. And then, of course, post the clinical studies that Pfizer and Moderna executed, we have been distributing the vaccines on the emergency use authorization. And of course, I mean, by this, this started back, I guess, the beginning of the year. And at this point, there's a huge number of people who have had the vaccine and are being monitored, and all of the vaccines that are distributed are monitored for follow-up. And so there's reporting that comes back into various databases in Canada, US, and in terms of the US, the number is well over 100 million by now. And so it's pretty easy to go and check and look at what the profiles are for people, the safety profiles are for people who have received the vaccine. And the profiles are still fairly consistent up to the last time I looked at them. So there's no indication of any reactogenicity other than the ones that we've talked about before. Other than the ones that were highlighted for a little while was what were associated with anaphylaxis. And the concern there was that it could possibly be linked to one component of the vaccine. And both Pfizer vaccine and the Moderna vaccine have similar components. They may be a little bit different in terms of their physical attributes, but it's both related to a material called polyethylene glycol, which is fairly common throughout the drug industry. It's used in cosmetics. It's used fairly widely, and I guess if you have an allergic response to it, then it may be a concern. But the only concern so far that we've identified is this particular one. And it's considered to be a rare event anyway. So that's kind of a very quick summary of the safety discussion. But the vaccines there's ongoing monitoring of the participants in the clinical study, except that I'm not sure if they're still monitoring the ones who received the placebo, because obviously there are ethical considerations to continue those people who received the placebo doses on without giving them the actual vaccine, because obviously that the demonstration of efficacy was extremely good for both of those two vaccines. So I know there were some discussions about what happened to those people. I don't know the results of that though. So that's a very quick summary, and if anybody wants to add to it, please feel free.
No, I agree with 100%, 200% with what Trevor has indicated. I will just make a couple of very brief points. It's in my clinical practice of infectious diseases, it's very frequently that we encounter situations where we have to counsel families about vaccines and their safety. And in that regard, I often, within my own mind, have a scale that I, have like from 1 to 10, where 1 would be a terribly toxic and unsafe vaccine, and 10 would be the perfect vaccine. And the pediatric vaccines now that we use to prevent things like meningitis and pneumonias, they're really close to a 10. They're really good. These vaccines, particularly the ones that came out first, are really close to a 10. And Trevor has really articulated that. They're really up there. They're in the 8 to 10 zone, which would make them among the safest vaccines that have ever been made. Now, Trevor's highlighted a very important phase of the process, and that is the post-marketing phase, where one administers a vaccine and one puts in place surveillance mechanisms to pick up signals. Those signals are rare. By definition, they're rare because you're looking at picking up signals that occur among millions of doses of vaccines being administered. And so when those signals happen, then one looks more closely to see whether or not they're really true signals that are related to the vaccines. And so overall, we're looking at very safe products.
Thank you. A bit of a follow-up to that question. Dr. Aldridge mentioned that there are different types of vaccines. The ingredients are quite similar, but they may function a little bit differently. So a little bit of a follow-up. How do we know that the different types or the different ingredients in the vaccines are safe? Specifically when we talk about AstraZeneca, there's been lots of controversy around that specific vaccine.
I haven't specifically looked at the AstraZeneca formulation myself, so I can't really comment in detail on that. But there again, when you're designing a formulation, you have criteria that you want to meet. You have some performance characteristics that you want the drug product, whatever it is, to meet in terms of the formulation. And it depends too, in some cases, on how you're going to use it, the route of administration. All of those are factors in what you're doing when you're developing a formulation. But the actual components are pretty critical, and some are have different risk factors associated with them in terms of some of the risks that people might be concerned with. And one that's been very, very common for quite a number of years now is concerns around effects such as Creutzfeldt-Jakob disease, and you'll be looking for things like materials that have origins from animal in origin materials, or things like that would confer risks for like that. So those are some of the things that you look at in your formulation to make sure that you're not adding those risks that you're already, or that you're controlling them. If, for example, if you're using materials that have sources like that, there are processes that you would go through to inactivate. You're looking basically at eliminating prions that can actually be active in your product. So you're looking at ways of inactivating it so it doesn't cause you any risk in your product. But in that vein, it's a kind of a similar approach. You're doing risk management. You're doing risk all along the way. You're constantly assessing risk of inputs into your process, inputs into your product. So that's basically, and again, those things are sort of built into the process now because we've seen where the risks come from a long time ago, and you build those in. The only thing I would say is the two first vaccines that we have, because it's a new platform, and it's somewhat unique in terms of where we are in terms of vaccines at this point in time. And you can well imagine everybody's eyes were on these two first vaccines, and in terms of the follow-up that Upton referred to, even the CDC were quite clear that this was the most rigorous follow-up they've ever done on any vaccine product.
If I may chime in there, I think you ought to remember that whereas in a clinical trial, you're dealing with 40,000, 30,000 numbers, we now have real life experience with these vaccines, where millions, probably we're reaching hundreds of millions, have received the vaccine. So if there's a very rare event, like 1 in a million, that you may not have seen during the clinical trial, you will probably see it in the real life implementation. And so the reference of the question was to the AstraZeneca vaccine. So in the UK, after vaccinating nearly 17 million people, they saw a few incidents of blood clots. So that was a signal. But to assure people that the system is working, it was not overlooked. People identified it. And in fact, actually, there were decisions to suspend the vaccination momentarily to allow them to look into the connection between the AstraZeneca vaccine and these incidences of blood clots. That's to assure the public that the system is working. And in fact, in many jurisdictions, they've decided how to redeploy the AstraZeneca vaccine because of those observations. So the public should be assured that as millions and millions and millions of people receive these vaccines, we're going to see signals of very rare side effects or adverse events. which happen with every medication and every vaccine. So that is not to say that one should shy away from these vaccines, but it is an awareness that one should have and an assurance that the system is working to identify these very rare reactions to the vaccine.
So Neb, can I add to that? I agree again with everything that Isaac and Trevor have said. One of the things that I've been personally impressed with is how transparent the manufacturers of these vaccines have been with respect to the ingredients. And in fact, what's in the vial is really quite simple. And there's some differences, but the most important thing is that there's nothing that's in the vaccine vial that is not labeled. That there's nothing hidden. It's all there. And in gross terms, it's actually for the mRNA vaccines, it's actually quite simple. It has the mRNA, it has a lipid, it has some other chemicals, one of which is has been alluded to by Trevor, called polyethylene glycol. It's used in cosmetics and bowel preps and laxatives. It has sugar, water, and some salts. It's really quite simple. And I often think of it as like having a raisin. This is for the mRNA vaccines, having a raisin that is coated by chocolate, where the lipid is coating this mRNA product. The other vaccines, for example, AstraZeneca, is not, it has a little bit more, but it's not very different in terms of the transparency of what's in the vaccine, in terms of the chemicals, and sugar and water and salt, polysorbate, ethanol, histidine. These are various chemicals that have been used and are being used in various medications. Key take-home point, though, is that there's nothing that's in those vials that is hidden.
Thank you all. So I'm going to pivot slightly, and we're going to talk a little bit about the side effects of the vaccines. So I'm making the assumption that Dr. Abdurrahman, these will likely be responded to by you, but anyone free to answer. So the first question is, can you just explain the side effects that individuals can expect when they receive the vaccine? And are men or women more likely to have severe side effects?
Okay, I'll take the first stab, and then I'll let anyone else join as well. In terms of the side effects, with any vaccine, your body is trying to mount an immune response so that it can recognize this type of, if it's a virus, a bacteria, whatever this pathogen is, when you're next exposed, so it can fight it very effectively. So with these vaccines, the two different kinds, the mRNA, the viral vector, they induce the same responses as other vaccines that you're used to using. And actually, a lot of these side effects are just your immune system working. And this is why a lot of people often think they've caught a cold or they've caught, the flu from the flu vaccine, because they experience a lot of the same things they associate with getting sick. But this is actually your immune system working. So you might experience some localized swelling or pain or redness at the site of the vaccine. And that's one of the first things your immune system does, is actually surrounds the area and tries to cut it off to stop it from going to all parts of your body. Another response that we often use when we're trying to fight infection is to raise the temperature. A lot of pathogens are not able to survive at high temperatures. So the fever is actually something our body does to fight infection. So some people will develop some elevated temperature. And then you might just feel kind of that aches and pains and just feeling a little bit under the weather. And that's also part of your immune system responding, because it wants you to take it easy. It doesn't want you to run a marathon. This is not the time to take on like huge events. It wants all the energy and proteins to really focus on making an immune response to the threat it sees. So those are very common things that you might see when you get vaccinated. And so that was noticed with each of these different vaccines, as well as in other vaccines that we typically use all the time, like influenza vaccines, diphtheria vaccines, shingles vaccines. With vaccines as well, we sometimes see people have, allergic reactions to them. It's very rare. Sometimes we see it in the range of about 1 in a million. With some of these vaccines, we're seeing sometimes up to 5 per million, which is still very, very low. And with that, obviously with that, they're quickly managed. And that's why all the sites are able to manage any kind of these extreme responses as well. In terms of who can see it more, with a lot of the vaccines, actually, what they found were people who were much older, so people who are like in their 70s and 80s, actually had a bit less of those side effects, because the things I was describing to you is a part of your immune system that's kind of the hardwired part that we rely on when we're younger. So we see it a lot more in kids. They get a lot more fevers after vaccines versus adults don't. So that wasn't unusual. There wasn't really a difference between men or women. It was more just the age-wise, and that's not surprising because that arm of our immune system becomes less active as we get older. So much older participants had less of the fevers with it, and some of those aches and pains, they had a bit less of those common side effects. So those are kind of the common things and the differences in the populations.
Great, thank you. Can individuals expect to have a more severe reaction after the second vaccine or the second dose?
Some people will notice a bit more just because your body has already seen something once. So it's really excited when it sees it again. And this is kind of with the booster. So you might see more of the local effects, sometimes a bit more, but not necessarily. A lot of people also get these vaccines and will not have any significant side effects, right? But there is a chance that you will have a bit more of a response with the second one. And that's because you're boosting at that point. So your body recognizes it a bit, so it can respond kind of even more robustly. So you can see some of that. So people have complained of a bit more of the aches and pains, a bit more feeling under the weather with the second dose. So that's not unexpected. And we actually see that too in childhood vaccines as they get kind of repeated ones. Sometimes with the later ones, they see a bit more of the kind of fevers or feeling unwell. And that's just part of your immune system. So as much as people get worried about some of these common side effects, it's actually just your immune system working.
I agree with Zainab 100%. There's a general principle that that we often see as well in clinical practice, and that is when you think about how the immune system is responding to the vaccines, what the immune system responds to in the vaccines is actually reasonably similar to what the immune system would respond to when you get an infection, generally speaking. So if you have what we refer to as reactogenicity, in other words, you get the soreness and the aches and fevers that as Zainab alluded to, and if you think that those are relatively significant and you're concerned about them after you've gotten the vaccine, it's not unusual that in some situations, we often say, if you had gotten the natural infection, in other words, if you had gotten COVID, or if it were, in the case of influenza, your reaction actually, the way that your immune system reacted would probably be even more profound. So in other words, it's probably a good thing that you got the vaccine, and you might have been sicker if you had gotten the natural infection.
Mm-hmm. Thank you both. That's a good reminder and a good point to make, that that some of those side effects are indicators of a vaccine that is working, your body responding in the way that it should. What do we know about the long-term effects of the COVID vaccine? Are there any long-term effects?
Well, I guess it depends on what we mean by long-term. Obviously, people have been getting vaccinations since early in the year. The people who were in the clinical studies have had the vaccine for going on about roughly almost a year now. I mean, I think some of them started very early in the summer, so they're probably around the 10-month range by now. So that's in terms of long-term effects. I mean, the only thing that you can determine is just where you are at any point in time. And in terms of what the profiles look like, I said before, the adverse event profiles have not changed since the early reporting that was done from the clinical studies and as we started distributing the vaccine. So if someone is talking about, I mean, what can I expect after, 2 years, this vaccine being in distribution for 2 years? Nothing has changed. We see the same profile up to now. So in terms of, what happens in real life has to happen, and that's what we're waiting. We don't expect to see it, but nobody can tell you what to expect other than all the indications are that there's no reason to expect anything different at this point.
And just to add to that, I think what's important is we have had these, the people who were in the studies who were the first ones to get this, and we've had a lot of time to follow them. And now, we started distributing this just before the new year began in Canada, and other countries started before us, namely countries such as the UK. So we have as much data as we can now. And what I would also say is, the one thing we do have too to compare is when people get COVID, we're seeing them getting a lot of long-term effects, and it's coming on pretty quickly and following their infection. And we have not seen anything like that with the vaccines. And that's because the vaccine does not give you COVID itself. It just gives you a small part to make your immune response from. So we've not seen anything like that. So in terms of long-term effects, the things that we're very concerned about, because I know a lot of people counter this with, why don't I get natural infection instead? With natural infection, we're seeing a lot of long-term effects. Some people are calling it long-haul COVID, but we're seeing a lot of neurological effects, a lot of effects on clots and on the heart. So we are seeing that from infection, but we have not seen any of those signals with our vaccines. So when you're also trying to determine which one is the safer one, the vaccine is absolutely the safer one of the two.
And just one other quick point to make, and that is, in terms of monitoring for adverse events, that's a global effort. So we're looking at data from all over the world when we talk about pharmacovigilance monitoring. So, if anything is happening in the other side of the world, we will know about it. So, in that case, anyone who picks up a signal can always, transmit that signal, to everybody very, very quickly. So it's pretty clear that, in terms of worldwide monitoring, we have not seen anything that suggests up to this point, anything other than we have described before.
And I guess the other thing to remember as well, that again, just based on previous experience, generally speaking, vaccines don't usually cause long-term effects. Most of the side effects from vaccines tend to happen within days, weeks, months, rather than years, generally speaking. And so that's, so most of what we would experience, we would likely see within a matter of months, and certainly well within a year. But I know people are often asking, well, what about 5-10 years from now? It's highly unlikely. That said, those types of events, if there were to be vaccine attributable, would be incredibly rare, and would be captured using the post-marketing detection signals that Isaac and Trevor and myself have alluded to earlier on.
That's a great point, in that I think what people forget is that we've known about vaccines for a long, long time. Sometimes we take them for granted, but we use vaccines a lot. It has helped society. We know how to follow up for them. So on the whole, people shouldn't expect things to be very different and make themselves susceptible to misinformation. We know what vaccines do. Flu vaccines are given every year. Children get a whole host of vaccines, multiple of them. And we haven't seen any long-term harm to children. So that should give people assurance that this is no different from our experience with vaccines in general.
Great, thank you. I think you have done a great job of explaining the benefits of being vaccinated to prevent infection and combat some of the long-term and severe effects of COVID-19. What about individuals who have already been infected with COVID-19 and may have some level of immunity already? Is it still valuable for them to get the vaccine? And if they are vaccinated, can people still spread the virus?
Yeah, we do recommend that even if you've been vaccinated, even if you've had COVID, you should still be vaccinated. There's a well, publicized case in the Caribbean of the Prime Minister of Trinidad, who I think on the day that he was supposed to be vaccinated, got tested for COVID and was positive. And so his plan is still to be vaccinated. He'll have to wait a bit, but he'll still be vaccinated. The second point to make is that if you get vaccinated, you should recognize that there are differences in the variants of concern that might be emerging, and so the vaccines do offer varying degrees of protection against the variants of concern. It's possible that in the future, one may need a modified vaccine booster doses if very different variants emerge in the future. And often what happens in those situations, your booster dose is a booster that by definition has been primed by previous vaccination. So being vaccinated now might facilitate things later on. It is still possible that you might transmit virus even after being vaccinated. The hope, though, is that transmission would be less. There are more and more data that are emerging in that regard. But for now, there are certain precautions that one still need to follow after being vaccinated, and one needs to stay plugged into, in the case of the Americans, the CDC, in the case of Canada, Health Canada, and our local public health, to see what is allowed after you've been vaccinated.
I want to add one thing, and that is there's a question that came up, and I don't think it's been fully answered. So if you've had COVID and you get your first vaccination, the question is, do you still need to have the second dose? And the studies that I've seen suggest that there really isn't much of a difference in antibody levels after if you do get the second dose. So it sounds like your initial COVID infection is that is boosting your immunity, and then your first dose is actually acting like your second dose. So that's the only question I don't think we're fully answered yet, whether you do need to get 2 doses after you've had an infection.
I guess I would just add to that, though, that the current recommendations are you still receive the 2. That hasn't changed from Health Canada. So we are not recommending that you do not get the second one. The current Health Canada recommendations are still to have the 2 doses, even if you've had previous infection.
Right.
Right.
Okay, thank you. So we've had lots of questions about contraindications or groups of people who should not be receiving the vaccination. So for example, those with who are immunosuppressed, or those who have sickle cell anemia, other pre-existing conditions that might mean that you cannot take the vaccination. So do we have an understanding of what those conditions are? And could you share that?
I'll start, and then I'm going to pass it off, because I think that this is where it's really important. We're talking about a lot of different groups, and there are the ones where it's, very clear guidance as to people who should not. And then there comes times where you have to have a discussion first, and you have to talk about risks and benefits. The ones that are clear that, you do not go straight to vaccination is if you have an anaphylactic reaction to your first dose of the vaccine, then you will not get put right into the kind of plan for another one. You'll have to get an assessment, and they'll have to do some special assessments for you prior to determining if you can get another dose. If you are known to be allergic to a component for which we talked a little bit about polyethylene glycol, if you've previously been identified with having an allergy to that, then you are required to see an allergist prior to getting your vaccine. I will tell you all that is an extremely rare allergy with very few people. I think when we polled all across the allergists in Ontario, there were less than 50 cases. And that's because PEG is actually present in, I think it's something like over 30% of the medications that we buy over the counter, as well as most laxatives and a lot of makeup products and foods and drinks, etc. So those are the ones that are kind of an easy population that would not go straight to vaccine. After that, though, then there are special populations where there's a discussion that needs to be had. People often ask me about, what about immunocompromised patients? And the thing I have to tell you is immunocompromised patients is not one group of patients. There are so many patients who fall under this. It just means your immune system may not work as well as it should. So, and for a lot of people who have this, they're still able to go for the vaccine. There's some people where their immune system is so compromised that we wonder, the vaccine won't hurt them, but we just wonder, will they be able to mount that response we want them to make? It's not that it's, particularly dangerous. We just don't know if they'll mount it. So they could still get it, but they may not mount the same response. These people often have other treatments that are in place to protect them from infections in general. So it's not that it would harm them because these are not live vaccines, so they cannot get infected from them, but they may not mount the same response. I'll pass off to others to talk about other kind of special populations as well. Perhaps maybe Dr. Odame first, because I know you mentioned sickle cell as well.
Yeah, for those who have sickle cell, I don't know whether many people know this. When sickle cell anemia children are very susceptible to certain infections. So we have a fetish approach to their getting certain vaccines. In fact, they get more vaccines on top of what every child gets. And sometimes the parents wonder. And it's because they are very susceptible to certain infections. So vaccinations in sickle cell patients actually helps them rather than harms them. And we believe that just like the flu, if they do get COVID and you have sickle cell disease, you are at a higher risk of getting the severe form of the disease and getting complications because you have sickle cell disease. So as a result, actually, provincially, priority is being given to those who have sickle cell disease to get the vaccines if they could get ahead, because they need it more to be protected against COVID. So I will encourage you, if you have family members, or if you have children or adolescents, or you have relatives friends who have sickle cell anemia, do encourage them to take the vaccine. A priority has been set for them to get it because of the consequences of COVID in this group of people.
Yeah, I think that one other point that should be mentioned is that the populations that are targeted for vaccination typically are those that were evaluated in the clinical trials. And so when the companies file to Health Canada, the European Medicines Agency, the FDA, if they did a study that included individuals 16 and above, they can't make a filing, typically not. They can't make a filing that says, we're gonna file for using this vaccine in individuals of all age groups, okay? And so the reason why certain age groups might not, in this case, children, were not included initially, and they're simply because they were not in the clinical trial. So that's all. The other general comment I would make, and Zainab captured this nicely, is that for the most part, as far as safety is concerned, the only real contraindication at this point, absolutely, well, maybe it's relatively because you want to discuss this with your doctor and allergist, is if you're allergic to something in the vaccine vial. And this has been made reference to earlier. Beyond that, as has been said before, the issue is not so much whether or not people with different underlying chronic diseases will have a safe journey through vaccination, but rather whether or not their immune system would respond effectively to the vaccine. And that may require special considerations for them in terms of how they're monitored, with respect to trying to determine how well their immune system responded. And so there are some studies that are being done now to get a better understanding of what would happen if you vaccinate somebody who is on dialysis. What happens if you vaccinate an organ transplant patient or a patient with cancer? There are no safety issues. It's just a matter of how well does the person respond.
Great, thank you. So we're going to take one more question, and then I think we'll take a bit of a break. And so I think I'm going to direct this one to Dr. Khenti. And this is just around the variants. So do the current vaccines that we have work for the variants? And is it true that the variants are mainly affecting a younger population? Oh, you're muted.
Yeah, so that's yeah, the variants, the variants are now impacting people under 40, and for the, as compared to wave 1 and wave 2. And we have a real public health disaster on our hands because we're rapidly losing our ICU capacity to take on more COVID patients. And it's really because the UK variant has sort of become the dominant COVID strain in Ontario, or is becoming. And so the good news, so that's the bad news. The good news is the 3 vaccines all work against seemingly the variants. There's some question about the AstraZeneca vaccine from some research in South Africa, but it's still an open issue. But in terms of mortality and hospitalization, which are the 2 key areas where vaccine dependability or vaccine efficacy matters, the first vaccine you get an opportunity to get, take it. They will work to save your life and reduce the severity of the illness, regardless. That's not to say that they will continue to work, but right now in the 6 month, the period that we're in, they'll work, and they'll work for at least 6 months. So do what you can to get a vaccine in your hand as quickly as possible, because those variants are eating nice. And we can get back to that after the break.
If I may add in here, I think that the way I view this is that there's a competition between how the variants are occurring, the pace at which variants are occurring, and the pace at which our vaccine rollout is going. At the moment, it seems that the variants are spreading much quicker than our vaccine rollout is occurring. So if you are disturbed by the data you are hearing about, our health system is in danger of being overwhelmed, it is the more reason we have to accelerate the pace of taking the vaccines, because viruses by their nature, they mutate. Luckily, they need us humans to be able to multiply. If we let this COVID virus, other variants will occur because there's a high number of infections going on. And the more and more that is happening, the more likely that a mutation, a variant will occur, which is going to be more transmissible and cause more disease. So we are really at a very pivotal point where we all need to come together and say, how can we overtake this virus, protect ourselves? If you're not worried about yourself, at least your loved ones, the people in the community who are more vulnerable in terms of what will happen to them when they get the COVID infection. So Ontario is at a crossroads, and I think this is something that we should all work together at. And that is why the province has taken very draconian measures of saying that we should all sort of hunker down and be restricted in our homes. I think it's just the reality, because not doing that will be totally irresponsible and will be very catastrophic. So the way to fight it, if you are anxious about it, is to go quickly get your vaccine at the earliest opportunity.
Yeah, and if I could just add one quick comment to that before we go to break. We're talking about the vaccine equity issues related to our experience as Black people, as a minority group in a society of white people. But there's another huge vaccine equity issue that touches on the lives of all of us, because many of us have relatives in Black countries of Caribbean and Africa and Latin America, where they don't have any access to vaccine. There are 30 countries in the world where not one person has gotten a vaccine, and most of them are in Africa. So this is a huge vaccine equity issue. And when you talk about variants, when you leave people unvaccinated, you're creating conditions for variants to not just emerge, but they'll be more voracious when they emerge. So that's the other vaccine equity issue that we don't really have time to deal with in these forums. But remember, we are part of a global African experience, and we have relationships with family members that we also have to worry about. That's the sort of the double burden of being a person of African descent living in America.
I just remind everyone just of one thing very quickly, and that is, because this sort of touches a little bit on the whole vaccine efficacy discussion. And everyone needs to remind themselves that, when you do the studies to assess efficacy, they're not all the same. We're not doing head-to-head studies. We're not comparing things exactly the same. So for example, obviously the Pfizer and Moderna vaccines have pretty high marks for efficacy because of the time when they were done. There weren't any of those variants circulating at that time. So just remember that. Some of the studies that were done when some of the UK and South African viruses were circulating, it's probably the ones you want to look at as well, because that gives you some measure of what the efficacy may be for those variants at the current time. And we do know that both Pfizer and Moderna have done some studies that demonstrate that there is some degree of efficacy for the variants. I don't remember the numbers off the top of my head, but they have done some demonstration of that. But the whole point is, those clinical studies were done at offsets, and obviously the ones done early in the summer with Pfizer and Moderna, done in the US primarily, only saw the original virus that we were discussing. The ones that were done later in other countries saw other variants.
So Zev, Trevor reminded me of something I wanted to mention, and I think it's touched on a little bit earlier, and that is when vaccines are used, generally, we try to aim to prevent three things primarily. Number one is that we don't want anyone to get infected. So we call that preventing any infection, including mild infection. But sometimes, people get vaccinated and they still get mild infection. Then number two is that if they get mild infection, we don't want that to become severe infection. So we're preventing severe infection. And the third thing is that we don't want people to end up in ICU and die. These vaccines are all almost 100% effective in preventing that last two categories that I made reference to, severe infection and death. So we're talking about differences that relate to the milder end, which many of us can live with. If that's what we're going to get, I'd rather get mild infection than severe infection or dying.
Thank you all. So I am going to move us into a quick break. When we come back, we'll talk a little bit, we'll answer some more questions, talk a little bit more about building vaccine confidence in the Black community, and then some of the equity issues that we've seen. But I'm going to give us a 5-minute break. So go stretch, grab a drink, whatever you need to do, and we'll be back in 5 minutes. So we are welcoming back our panelists. Hopefully you're ready for another round for some more information. So I wanted to start this next section just talking about, we ended off talking a little bit about vaccine equity issues and just some of the concerns around vaccine trust in the Black community specifically. So I just wanted to go a little bit further in that discussion. And so Dr. Khenti, why would you why should we as Black Canadians have the same concerns that some Black Americans have with vaccine confidence and receiving the vaccine when we've not necessarily had the same experiences and have the same history?
Yeah, so that's a very powerful question, and it's a very relevant question, especially because of the diversity of the Black Canadian population. We have people from all parts of the world, all geographies, religions, languages. I think we have as much languages from Africa as there are in many parts of Africa, hundreds of languages. So we have a very multicultural Black community in Canada, probably the most in the world. But you know, despite that multicultural diversity, second generation Black Canadians begin to sort of have the same health indicators, regardless of where their parents came from, because of the social determinants of health and systemic racism that exists in schools, exists in health, exists in child welfare, exists in the criminal justice system. And if you had time, I'd actually spend a lot of time talking about that. The Tuskegee experiment was in the US. Henrietta Lacks, the decisions that were made about her cells what happened in the US. But the Black population in Canada have always been connected to the US. Whether it's Black loyalists, enslaved Black people running from America, Black people enslaved running from Canada to America. We have that slavery experience in common. And that slavery experience has given rise to a whole range of stereotypes and stigmas, public stigma, which affects our populations today, similarly, in similar ways. And what's important to note is we experience racial discrimination to similar degrees. And I know people don't think that, but they haven't had data to compare our experiences to African-American experiences before. We know now, in the prisons, we have similar rates of incarceration. When it comes to police shooting of people of color, we have similar rates of police shootings, fatal police shootings. When it comes to the health disparities from COVID, we are similarly impacted, not the same scale, but similarly impacted. Our mortality rate from COVID in Canada is 35 per 100,000 versus a white mortality rate in Canada of 16 per 100,000. In America, it's 100 per 100,000 for Black people and 50 per 100,000 for white people. So big difference in terms of scale, but same twice the rate. Black people in both places are dying at twice the rate of their white peers, which tells you, and actually the hospitalization is the same issue, 2 or 3 times the rate of hospitalization vis-a-vis their white peers. Most importantly, perhaps, we are disproportionately represented in healthcare, not just as nurses and doctors and family care and physicians in primary healthcare, but as orderlies, as nursing aides, as PSWs. And in Ontario, it's about like 30%, I think, and of that 30% that are Black, it's about 80% immigrant, 30% Black, 26% Black females from Nigeria, especially Jamaica and Haiti as well. And because of that preponderance, the risks are multiplied and amplified for our populations. And we in those professions, despite over average education, 40% and a half degrees, university degrees, but because of social determinants, because of systemic racism, we just have to take the work. And we take the work, but we get a lot of health risks coming with the work, and end up with these health indicators, which indicate very clearly that we are at greater risk, racialized risk, vis-a-vis our white Canadian peers. And that is a very serious thing that we have to understand and address. I hope I answered the question.
Yeah, thank you.
Yeah, Neb, if I may add, I think from the way you asked the question, you're digging into the mistrust. Is that right?
Mm-hmm.
And what that question reveals is that the mistrust that Black people have is more related to what their daily experience is, rather than maybe purely historical issues. So they are saying that our histories are slightly different. We come from different origins, but our daily experience of racism and being denied equal opportunities, equal access to things is the same. So a Black person with obesity seeking treatment gets a different attitude in terms of how he or she is treated in the healthcare system compared with a white, okay? Housing, access to opportunities. So it is these daily experiences of Black people, wherever they come from, whatever their history, they all have that common experience, whether they live in Canada, US, UK. And that's why there's similarity in the social determinants of health leading to health outcomes, although we live in different places and we have different historical backgrounds. So it is that mistrust that underlies how Black people feel about the system, which they are linking to the COVID experience. And what the task force is trying to say is that, yes, we experience it. Yes, we recognize it. Yes, there are disparities in outcomes. But on this issue of vaccine, for now, let us not widen that disparity by not trusting the vaccine. So hopefully the scientists like Dr. Upton, Trevor Aldridge, Dr. Abdurrahman, all these people that you trust, that you have some level of confidence in, hopefully what we are saying will help you a little bit in coming to a realization that taking the vaccine is a smart way of making sure that outcomes for our community are better than what they are now. So, and we hope that this information will be helpful so that your decision-making is not based on some misinformation or misunderstanding, but is rooted in science and evidence.
Absolutely. Thank you.
Quickly, just a personal note. You go, there's a Black experience. What people come here from different places, they have cultural diversity, incredible, we're so different. But you come here and there's a Black experience. And so if you end up in an ICU, I've been in ICUs in the past few years, but I have elderly parents and they've gone through many crises. I don't leave them alone. You understand? I don't leave, a family member always has to be with them. My shift done, my sister has a shift. When her shift done, my cousin has a shift. We don't leave them alone. But under COVID conditions, you are left alone. That just tells you that's a situation to be avoided. If I'm telling you, I ain't leaving my parent alone in an ICU. I work in the healthcare system, I work in the hospital for 20 years. I'm telling you that, you know.
Yeah, that's powerful. That's something to really think about. I'm wondering, so, I mean, given the fact that COVID does disproportionately impact racialized and Black communities, and there is this mistrust, I mean, sessions like this are great, but what else can we as a community be doing to help build that trust? And then what else can be done to improve access to vaccines for the Black community?
I think it's a really great question. I think it's really important for us to get a better understanding, and this is a work in progress, but a better understanding of why different groups of folks are hesitant or might be hesitant. What are the trust factors there? I think that's really important to try to get a better understanding of that, so that we can help them to make decisions. Because ultimately, I think it's really important and that we all recognize that nobody can be and nobody should be forced to be vaccinated. It just couldn't happen and shouldn't happen. But what would be really sad if people end up not being vaccinated, or they're at the end of the line to be vaccinated because they acted on wrong information. And so sessions like this one are aimed at ensuring that people are acting on the right information. And if somebody, having been provided with the right information, decides that they don't want to be vaccinated, that's their right. But at least everyone would sleep better knowing that they had the right information and they made an informed decision. But it would be so sad, really so sad, if somebody decided not to be vaccinated because they thought the mRNA vaccine was going to change your DNA, which it doesn't, you know. So those are some of the reasons why I think we need to get a better understanding of why people are hesitant so that we can help to fix that.
And I would also add to that, you know, you asked what can we do, or anyone who's listening is, you know, join the conversation. I know we're all on a lot of WhatsApp groups with our family members, lots of aunties and uncles who have lots of comments. And, you know, I'll tell you, before COVID, a lot of the times I let a lot of the comments slip. I just let them go. You know, there were some fights that were not as important, you know, whether this type of water or adding certain things to your water, you know, gave you better health. But now for this, when it comes to the vaccine, I do speak up because I do think it's something very important that is, you know, affecting lives, like lives are being lost, you know? So, and the information is so rampantly being spread about, and specifically misinformation, and knowing that our population is being, you know, disadvantaged in terms of being more affected, dying more, and knowing that it's only going to be from within that we're able to really change what's happening to our population. So if someone is saying something, you know, and you've learned from here, feel free to share that knowledge. And there's a lot of great resources from the Black Scientist Task Force with all this information as well that you can refer people to from, I'm sure, within the region of Waterloo that was mentioned as well, that you can give people information now and, you know, interject in these conversations, because this does make a difference. This could, you know, affect whether or not this loved one makes it through this pandemic. You know, it's very different from before, you know, when we might be talking about something that, you know, during cold and flu season, if you drink more or less lemon water is not, you know, something that's going to, you know, hurt someone, but potentially choosing not to get something that could potentially save their lives based on misinformation could really make a difference. So, you know, engage with your family members, engage with people within our community, because you know what, there is a level of mistrust with people who are coming from outside, seemingly dictating to us things to do. You know, you would be more trusted over them. So share the information you're learning on these different panels, share it and talk to people. So that's what I would say there.
You know, I just want to make a few comments, and it's more framed in terms of questions, because you know, what I'm not really understanding very well is in terms of what anyone thinks they can do for themselves to prevent getting a COVID infection, is what's not clear to me. I mean, if you're not planning to go and sit in the mountain top for the next 6 months and isolate yourself totally, and you're going to be, you know, part of society, and you're going to be mixing with people who potentially may have the disease, what do you think you can do to protect yourself? I mean, you know, I'm not sure people have really asked themselves those questions. Certainly, if you decide to take the vaccine or not take the vaccine, that's a decision that you're making yourself. But you can certainly, you know, acknowledge that, okay, I'm not going to take it because I, you know, for whatever reasons, and I'm willing to accept the risk of not doing that. But just walking down the street, you know, you're exposing yourself potentially. I mean, how many times you walk down the street and there's somebody hacking and coughing and right in front of you when you're, you know, 5 feet away? So you're already in lots of situations where you potentially are exposed. So if you're not taking all the ultimate precautions to prevent yourself from being infected under those conditions, what are you thinking? What are you thinking that you can do for yourself? I mean, people need to really articulate what their concerns are very carefully, at least try and answer for themselves, or if they want to listen to somebody else who might be able to provide them with answers, that might be a good thing as well. But it's almost as if it's a bit of magical thinking, it seems to me, when people just sort of blankly say, you know, I'm not going to take the vaccine, or I'm not going to do anything, because I mean, if you're not a Republican and you're not going to sit on that mountaintop, I'm not quite sure what you're thinking.
So I will, just a follow up to that, and it is, and I'll toss it back to the panelists. I know that there are, we've had comments around the survival rate of individuals who do contract COVID. And so the feeling is, or the sense is, that if I don't get the vaccination and I contract COVID, that my chances of survival are quite high. I know we talked already about some of the long-term impacts of COVID-19 infection, but I think that is one of the things that we're hearing, is that the chances of survival are quite high. And so why assume the risk of taking the vaccination? And I think that might be a question that people might like to hear from the panelists answered.
You know, it's interesting. When we take vaccines, it's important that we recognize that we are protecting ourselves, but we're also protecting our loved ones. We're protecting people around us. We're protecting people who are perhaps who might have a higher risk of having severe outcomes and even dying as well, including people with weakened immune systems, our parents and grandparents, and others around us. So it's really important for us to remember that. And as was said earlier by Isaac Odame, viruses need cells to divide, and we are, you know, a vehicle that moves around with these cells and facilitate transferring of a virus from individual to individual after the viruses have had a chance to replicate. So we're not only just protecting ourselves, we are protecting our loved ones, and I think that's really important for us to bear in mind. And we all of us, I'm sure, have known somebody who has died from COVID, and that's so sad that during the break I found out that a family member in Switzerland died from COVID, and just 10 minutes ago, and someone in their 90s. So there are people who are more vulnerable than we might be, and it's really important for us to bear that in mind, to help protect those individuals.
And I just
chime in here. I think Dr. Khenti alluded to it. The typical thing about Black culture is the sense of community and family. That's something that we have embedded in our culture. So when you're thinking about this issue, think yourself as not just an individual looking at yourself, but looking at the community as at wide, and your family and loved ones. That's number one. Number two, this pandemic is unprecedented. None of us alive have seen anything like this. The last time it was 100 years ago. So you're not comparing this experience with something you know. This is something uniquely different. When has nearly 600 people been admitted to Ontario ICUs for a singular infection? It's never happened before. So for those who might think that, oh, I will go through the natural infection and I will bet my luck and survive it, even though now we know that when you get the infection, you may have long-term effects as well that could affect you. I don't think that risk is worth taking if you consider taking a vaccine that is controlled. Yes, a few side effects because your immune system is going to respond. And then the bubble that you create around those you love, those that your mother, your auntie, somebody you have contact with, who has a much higher chance of dying from the infection. I think taken all together, we should really examine the facts, the evidence, and that's what this task force is trying to do. That is based on science, not on some conspiracy theory that somebody's propagating. But this is the time to ask the questions about the science, so that in the end, you'll be assured of the evidence and you will take your role as member of a community, a family member, and make a firm decision that you're going to be part of it. Lastly, one thing I've noticed about a lot of information on social media, they criticize the vaccine and how it's been developed, it's been rolled out, but they offer no solution. They don't say, so in light of that, we should just let things go. That can happen. And that's why Ontario is shutting down. If we need 700, 800 ICU beds, we are going to face a situation where you have to decide, oh, this one is 25 years old, this one is 55. Let's ventilate the 25-year-old. That would be unthinkable. So not offering a solution, but destroying everything that is going on. I think when you hear that from people, just politely ask them, so what do you propose in its place? What should we do in light of what we are facing? And I think one can have a reasonable discussion there. And ultimately, you realize that they have no real solutions for us, because this pandemic is unprecedented. We haven't faced a thing like that since 100 years ago.
You know, Zeb, Isaac makes me remember when we were preparing for what we thought was the great pandemic of influenza occurring, and we were doing a lot of preparation in the 1990s, and in fact in the 1980s as well, late 80s, when I was still in training, and then 1990s. And we were preparing for the great pandemic. One of the things that we rehearsed was, what would we do if we had only one ventilator, and we had a 20-year-old and we had a 50-year-old? And when you think about that, and we all said, oh, well, that would never happen. And we're now 2021, and we're pretty close to that. And so that's painful. I had no idea when we were going through these preparations, and Isaac, you'd have probably gone through this as well. We had no idea that we would come very close to that type of scenario. So when I hear people not wanting to be vaccinated, I think of exactly what Isaac has alluded to, and that is difficult choices when resources are limited to keep people alive, especially in the setting of intensive care.
Thank you. Those are great responses and great, great food for thought for those who are considering whether or not the vaccine is right for them, the pros and cons, and what they really need to be thinking about when making that decision. I have a few more questions from participants, specifically about their own circumstances, people who are trying to, again, figure out whether or not the vaccine is right for them. So I have a couple questions here for you. Are there risks to getting the vaccine for those who are planning on becoming pregnant, or who are pregnant, or breastfeeding?
So initially, when the vaccines came out, this was a question because those who were pregnant or breastfeeding were not actively recruited for the studies. But with looking at it over time, actually, there were patients who were in the original studies who then did get pregnant. And there was no kind of increased concern with those who did get pregnant during the studies who received the vaccines. There was no issues there. And actually, the Society for Obstetrics and Gynecology, who are the doctors who see these patients who are looking to get pregnant, who are pregnant, and seeing them immediately after birth as well, they actually were really fighting to get pregnant women included to get the vaccine, because they noticed something very disturbing, which is if you are pregnant and you get COVID, compared to females of the same age and stage of life, those who were pregnant had worse disease. They had worse effects on themselves as well as outcomes for the baby. So they actually started really pushing for this. It's not uncommon that when people start off with a study, they may not include some kind of certain populations. They may not start with children. They may not start with pregnant women. Now, some of these studies are actually being done similar to the way we're doing the children's ones. They actually are looking at the one looking at people who are pregnant. So, from those societies, they strongly recommend for those who are looking to get pregnant or are pregnant to be vaccinated, similar to the way they recommend the flu vaccine so that the babies do, get born with some immunity, because there is transference of your immune antibodies from mother to child in the kind of the last stages of pregnancy. So they want these babies to come out to have some immunity. In addition, there hasn't been any signs of it affecting fertility. There isn't, and these vaccines aren't really very different from kind of the vaccines that we're routinely using. Yes, the thought of mRNA may be a little bit different, but that mRNA is degraded within the first 48 hours. So that part doesn't last in your body either. And it's just your immune response that's the lasting part. So I can tell you that those, there are statements from these, from the groups of physicians who focus primarily on these populations, highly recommending it. So I hope that that kind of helps you. And if you are pregnant, you're talking to someone, whether it's your family doctor or your obstetrician, talk to them about it as well. And they can, go over it with you as well. Don't be afraid to ask questions to those who are taking care of you for whichever reason, if it's for pregnancy or any other medical condition where you're not sure about yourself and the vaccine. Engage in a discussion and ask them about it. You trust them to take care of you for your, for whatever they're caring for you. So trust them with this discussion as well.
That's great advice. We've had lots of questions about a number of very specific conditions, more than we can go through individually in this session, but I think that's great advice. If there is a specific condition that you have, speak with your healthcare professional about whether or not the vaccine is right for you and different considerations that you might need to account for. And I think, Dr. Allen, you touched on this earlier, but we've had questions also about the impact of the mRNA vaccines on an individual's DNA, or whether or not it changes someone's DNA, or how it works. So maybe you could speak to that, or any of you would like to speak to that.
Sure, I can address that. So basically, one of the myths that has been circulating is that somehow the vaccines, notably the mRNA vaccines, might influence your DNA, and the answer to that is no. And I tell you why. The way to think of it, the way I think of it is, I use the example of a peach fruit with a hard seed in the middle, and then there's that outer section that you eat, fleshy part. The Pfizer and Moderna vaccines get into that outer part that you eat, and that's where the immune response is triggered. Your DNA is in the inner part where the seed is, and so the two don't really come in contact with each other. Furthermore, as Zainab has alluded to, the mRNA, once it gets into that outer part of the cell, we call it, cytoplasm, the fleshy part that you eat. If you use a fruit example, it breaks down very rapidly. But there's something that's even more important, and that is our bodies, the cells in our bodies, and the enzymes in our bodies cannot convert the mRNA into DNA for DNA then to be incorporated into DNA. So you don't have, we don't have the complex mechanism that would even allow for the conversion of mRNA into DNA to be incorporated into DNA. And the proof for all of this is that we get infected with RNA and DNA viruses regularly. Adenovirus and common cold virus, influenza virus, and they don't change our DNA. So it's really important to recognize that the vaccines, what I'd say, mRNA vaccines or the vector-based vaccines will not change our DNA.
Thank you for that clarification. So at this time, we're coming up on 4 o'clock, and I wanted to open it up to the panelists if there are final remarks or just final messages that you would like to share with the group here. And then before we close out, I'll share some information just around specific rollout and registration information for the Waterloo region. So yes, panelists, is there anything else that you would like to share with the group?
Let's do it in reverse, from Z down to A.
Sounds good. Would you like me to go first then? Oh,
yeah.
the names. Sorry, go ahead. Sorry, go ahead.
Okay, I guess we're going by first name then in reverse. I would say there's a lot of, concerns and questions, and we're here and we're saying we fully understand why some of the concerns are there from, the lived experience, the lived Black experience for previous transgressions. And despite that history, we still encourage you to turn back this narrative where, unfortunately, as people of color or anyone of racialized groups are being adversely affected by this infection, take that back and let's try to take this, back to our communities with taking vaccines to help us return to our communities, because a lot of the ways as minority populations, we actually, thrive in the community is by being able to rely on our community. And unfortunately, with the way the pandemic works is actually by cutting us off from our communities. So if we want to go back to that and get the strength from within our communities again, I really encourage you to get the right information and make the right decision about getting vaccinated, because that is one of the ways that we will hopefully get back to being able to be part of our communities once again. People are always saying, well, I'm just not sure about the vaccine. I want you to think about it. Would you prefer COVID or COVID vaccine as well? That's what you should be really thinking about, because these are kind of the options that we're really discussing. And with COVID, there are real risks for death. And even if you get it and you didn't die, you didn't have anything serious happen initially, there's a lot of long-term consequences that can happen that can affect, your brain and your neurological system, your heart, and clotting. So there's a lot of negative aspects to getting the infection. It's not just like any other cold. So there's a lot of concerns there. And we've shown, and we've talked about it for the last few hours and really gone over the safety of the vaccines. So think about this in terms of yourself, your family, your community, and what you're hoping to get back to, and changing the narrative and taking kind of back what has been stolen from us by this pandemic. Thank you for joining us today. Upton, I think you're next.
Okay, no, thank you very much. I would say that there are some key take-home points that are worth noting, and that is, number one is that we all get it that the powers that be, including in the United States government, the CDC, pharmaceutical companies have definitely wronged Black and racialized folks for generations. You made reference to the Tuskegee example, and that experiment was a disaster. We know that from an ethical perspective. What was interesting was that Bill Clinton apologized for that on behalf of the United States government in 1997. That same year, there were ethical issues around placebo-controlled trials for HIV in pregnant women in Africa. Around about that same time, there was a major issue with an unethical trial done by Pfizer in Nigeria. So we get it. There have been major wrongs. That said, it's important to recognize that the COVID vaccines that are being developed are not, should not be seen as a white man's vaccine at all. And that they're major, important key players from Black and racialized communities who are absolutely pivotal in the development of the vaccine. So it's really important to recognize that we're part of the process of development. We're all in this together. And at the end of the day, it's important that as Black and racialized folks make decisions regarding whether or not they are going to be vaccinated. We want to make sure that people make those decisions based on right information, not on wrong information. If you do decide not to be vaccinated, and it's based on the correct information, that's your choice. I'd rather you be vaccinated, but I'd feel a lot worse if I heard that you didn't get vaccinated because of a misconception or being fed wrong information. Thank you.
I guess it's my turn.
I'm going next, I believe.
Okay, go ahead.
So my concluding remarks, as a Black person, I am concerned about the higher rates of mortality and the impact that this is proportionately having on my community. I truly understand the historical reasons for strong mistrust, and Dr. Allen has summarized some of them. But we cannot change those. The past is gone. However, we face daily experiences of racism in various ways, which is what contributes to our mistrust of the system. And by learning from our history, we have the opportunity to influence our present and future. And our present suggests that we're being disproportionately impacted by COVID. So the question is, what can we do about it? And I'm focused on changing our now and our future in relation to COVID. COVID did not create the disparities that exist. COVID has only brought it to light and emphasized those disparities. So I think we should begin a journey where not only do we advocate that the racialized communities have access to these vaccines, but that we continue to advocate against the system that creates those disparities. So let us help narrow the gap, not widen it. Because if we widen it, we are actually entrenching the status quo. Why can't we begin with COVID and let it be said that we became smarter, we became empowered, we listened to our Black scientists and doctors, and look, that disparity is beginning to vanish, that we are not dying more, we're not being admitted more into ICUs, that the opportunity to address these structural issues has begun. And what special condition can we really use as a model than COVID, which is a pandemic that we've never seen in our lifetimes. And currently we are in wave 3, despite all the efforts that we are making, that is overwhelming our healthcare system. Let us get our lives back. The only way to get our lives back is together, united, addressing the core reasons. So if you have a vaccine site close to you, please take advantage of it and don't hesitate. Thank you.
Okay, just want to say a few things. First of all, spent a good part of my life working for a vaccine manufacturer. And, you know, along the way, we've gone through the exercise of planning for pandemics. But I can tell you one thing for sure, we never imagined this. But having said that, you know, here we are. So how do we deal with it? So one of the things I wanted to kind of point out at this point is, you know, people have lots of questions around the actual vaccines themselves. And somebody had a question that was included in the list, and that is what this person was asking about was really actually a misconception. They're saying that the vaccine is still experimental. Well, that's not quite what it is. It's at the very last stage of development. You can't get much closer to a commercialization than this. And these are the vaccines that will be forever the index vaccines, index lots on which these vaccines are based. And so the fact that they have been given emergency use authorization tells me that they've gone through a very rigorous process. I've seen I've gone through the guidelines myself in order to obtain emergency use authorization. It's not much different from what you actually do to actually get an actual license for a vaccine. So the work has been done. You know, it's at the very last stages. I mean, the only things that you could possibly change without having to go through major change controls at this stage would be to do something like change the container closure. If you want to go from multi-dose vials to disposable syringes, which of course everybody would like to see, those are things you can do just by doing validation. But the actual intrinsic vaccine itself, we have those index lots now, and forever those will be the reference point for any changes to these vaccines going from this point forward. So these vaccines have gone through a regulatory process, and they are, you know, ready for use, and they can be changed at some point in the future. For example, I'm sure you'll be seeing other versions to address variants for booster shots coming down the pike, and a few other things that will likely come down the pike as well. But I wouldn't characterize these as experimental at this stage. So, you know, the person who was asking the question need to kind of rethink what they were actually trying to ask. That's it for me.
Thank you so much. Thanks to my wonderful colleagues. Thanks to all the people who organized this and are supporting this, you know, working behind the scenes like Ika, my colleague Ika, as well as your colleagues, Neb. You know, I just want to make four key points in saying goodbye. One is, oh, by the way, I saw a question in the chat about how long the protection lasts. And I anticipated that 6 months is what the latest research is saying for the Pfizer and the Moderna. I wasn't able to find anything about AstraZeneca, but, you know, and then we don't even know. I guess, like I said, the truck is being built as we're driving it down the highway. So it is what it is. But right now, 6 months, and 6 months is invaluable time during a pandemic, let me tell you. First point, you know, trust is hard to earn, easy to lose. And we're not here to ask you to trust the pharmaceutical companies, trust healthcare institutions or providers. That's for them to earn. They have to earn our trust. They have to earn your trust. They have to earn my family's trust, my community's trust. And that takes time. Trust earning takes time. You could use it like that. You can lose it like that, but it takes time to earn. So, but we don't have time. We're in a pandemic. So we tell you we don't want to build trust, but we're here as a trusted source because we're in the same boat with you. We're in the same boat with you because our families are in the same boat with you. And we're hearing the same thing from you. It's not just from you. I'm hearing it from my family members, some of whom are, at least one of whom is in this participating this afternoon, and I won't name them so they're not embarrassed. But I heard it from them. And you know, so we're not asking you to trust, we're asking you to think. Think through what you're hearing and seeing, especially what you're hearing and seeing on social media, and balance that with evidence. Because, you know, on social media, lies fly faster than the truth. And the same people that are disseminating those lies, they don't get fact-checked. You know, science gets fact-checked, but the lies don't get the same level of fact-checking. And I hate to say it, I heard two, but it got to me. People sent it to me. The mayor in Jamaica, I forget what city was in, Port Royal or whatever it was, telling people wait. The president of Zambia telling people wait. The deceased president of Tanzania, the same thing. Now, those comments by themselves may be very relevant in their local situations, I don't know. But globally, in a world where Black lives don't have the same value as other people's lives, non-Black lives, and I'm prepared to argue that with anyone, but you could just look at the neglected diseases of Africa and how long it's taken them to develop responses for those diseases. You understand? And they've been around for decades and easy to actually address, but not cost effective from a money-making point of view. You in a world that doesn't value Black lives, waiting is a luxury. I want to tell you that. Now, this is not the first pandemic or epidemic that we've dealt with. We've got HIV/AIDS still going on, Ebola still going on, Zika virus going on. We've got lots of stuff going on. And we will survive this the same way we survived that. The problem is we're losing encyclopedias. Brazil is losing the people who developed samba. In the Caribbean, we're losing some of the greatest music historians of the people who developed the same Kaison pan everybody's celebrating, gone through. All over the world, the same thing, encyclopedias. We have to protect our elderly, our seniors, and we have to do whatever is available to do that because nobody else is going to step forward to do that. This whole vaccine hesitancy conversation has to be put into context. Up until now, the vaccine hesitancy conversation has been about making vaccines available to Black people. That's what it is. Polio vaccine, from the polio vaccine in the early 20th century, they used to say, but Black people don't get polio. So they don't need the polio vaccine. Imagine that. Could you believe that? That's what they said. So imagine you're saying, I want to wait. And people out there this morning in Thorncliffe Park at 4 o'clock lining up for the vaccine. And that's in a high positivity area in Toronto. And I'm telling you, act fast, make a decision based on the evidence. Don't give misinformation and theories the same weight as scientific evidence. Don't. We are scientifically grounded people. We got more PhDs per capita in Nigeria alone than any other country in the world. It's just we haven't had a chance to translate that into power. Protect your health, physical health, but also protect your mental health. We have been stressed out going into COVID, just like every other Ontarian and Canadian. We're stressed out because of this situation, but there are things that you can do. Most important thing, stay connected. Call, Zoom, stay connected, but practice the social distancing. You're more likely to be at risk. You're more likely to have high blood pressure, high cholesterol, heart disease, diabetes, and asthma. You need to do more to protect yourself than others. And that's what it means to be Black in a pandemic. Done.
Thank you so much to our panelists. Yeah, can't explain how much the information that you've shared means, and I'm leaving here with certainly a lot more information, and I hope that our participants are feeling like their questions have been answered. I know that we were not able to get through all of the questions, and so I just want to share very quickly, I know we're at 4 o'clock, I want to share very quickly where participants can get that information that they're looking for about the vaccine. Frequently asked questions, we do have those resources at the region. So I'm just going to share my slide very quickly, and I'm just going to scroll through a few slides here. So one of the things that I want to start with is just that we do have a number of resources and a number of information sheets in a multitude of languages. We worked with community groups to develop these. And so it might be easiest to take a screenshot of this slide here with that link. You can find information specific to the Black community, specific to a number of different diverse communities, and in a number of languages. So I would encourage you, if you still have questions, to check the resources there. We have done a lot of work to answer to identify some of the key questions and answer those for a number of people. So please do check that. I also wanted to speak to, I'm sorry, I know I'm jumping around a little bit here, but I also wanted to speak to some of the priority populations. I saw a few questions coming in just around priority populations and vaccinating Black communities and racialized communities in the Waterloo region. So I wanted to make sure that everyone on this, in this session is aware that in Waterloo region, individuals living in key high priority neighborhoods, which are in general have high proportions of Black, racialized, newcomer residents. In those neighborhoods, you can pre-register for the vaccine if you are 50 years of age or older. So that is a little bit, that age limit is dropped compared to some of the larger population. So you can register if you are in one of these neighborhoods. So the Alpine Laurentian, Country Hills, Shades Mill, Vanier Rockaway, Victoria Hills, and Cherry Hills neighborhoods, you are now eligible to pre-register for the vaccine if you are 50 years of age or older. And you would be vaccinated at one of the existing clinics that we have in Waterloo region. We are also planning mobile clinics in these neighborhoods to make sure that the vaccination is easily accessible right in those neighborhoods. And so we're looking at starting at the end of April, so April 26th. Those would run probably until mid-May. There will be more information on that coming up. So I would recommend that you follow along on the region's website for that information, so that the link that I showed previously will have updates on those hotspot or those priority neighborhood clinics, as well as information about the vaccines and additional information sessions like this. If this is something that you're interested in and attending other sessions, that is where you can find all of that information. So I know that we are at our time, so I'm not going to share any more, but I would like to again thank all of the participants for joining us for your Sunday afternoon. Thank you for sending those thoughtful questions and for the opportunity to address some of your concerns and questions about the vaccine. And of course to our panelists for sharing your knowledge and your expertise with us. We very much appreciate it.